Hi everyone, welcome to the first verbal session of the conference. It's great to see you all here. My name is Ryan Kronk. I'll be moderating this session this afternoon on East. Our theme is East and Southern African WaSH. And first up we have Adrienne Lane from Water for Good. As housekeeping, we'll have a 10-minute presentation and 5 minutes for Q&A. If you can please grab the mic for those of us that are joining online so they can hear your questions. So we'll have the mics running around, so just raise your hand after the presentation. Go ahead.
Yes, thank you, Ryan. Hello, everyone. Thank you for the opportunity to be here today, and I look forward to sharing a little bit about the work that Water for Good has done to evaluate water quality and to better understand how to take the results that we have and evaluate them in an index to support decision-making for water safety management. So that's what we'll be presenting today, and the cases are from East Africa. I want to talk a little bit about what our objectives were for this research. Specifically, we wanted to understand what are the trends that we're seeing across regions and over time, and how is a water quality index a useful tool to better support decision-making and evaluation of our work in water safety management. We're specifically looking at the standards that the WHO guidelines provide for drinking water quality. And again, we have a local capacity to respond to the findings and to better support decision-making. So key takeaway and a key point for conversation can be how regular monitoring systems support the prevention of contamination, help detect contamination, and then help support response, so the management of water safety. I want to speak very briefly about our model, how we work in communities. We have a 3-year program, the Vision of a Healthy Village model, where we implement a holistic approach. We have an intensive phase that really focuses on engaging households, and then in that period we also typically install a new point of water source for that community. So these can serve households, communities, and healthcare facilities. And then we engage, again, more broadly around the management of the water point, and that includes a sustainability phase and the training and support of service provider groups who, again, are based in the community and responsible for the ongoing operation, maintenance, and management of water safety and supporting this monitoring work. So I'll just give a brief picture of what that really looks like. We have locally led operation and maintenance model operating in Ethiopia in 4 different districts. And what Water for Good does is do capacity building and training with the local service provider groups. Those service provider groups are focused on providing preventative maintenance and repair, targeting the repair to respond to any breakdown within 72 hours. This routine preventative maintenance can also provide the scaffolding on which to do water quality monitoring and, again, responding to issues that are discovered. The service provider groups are providing a service to communities, so we still have community management, and those communities are responsible for fee collection, and they manage and maintain the environment around the water point locally. I think importantly, there's a relationship between the service provider groups and the water user communities, and Water for Good is there as a capacity builder, trainer, and supporter long-term. My colleague Sarah Hollinger will be presenting some of the data that we collected and the way that we've used the water quality index to try to support better decision-making for water safety management. Go ahead, Sarah.
So for this study, we decided to look at some of our, monitoring data. So you can see here our monitoring framework that we use to monitor our water point quality. So these are the 3 main types we use. So we do regular monitoring. This is at 6, 12, and 24 months after we complete a water point. We also monitor at the institution level. This is done annually at all schools and health facilities for 5 years after the project ends. And then we also take a random sample of our water points. This is done at the country level every year for 5 years after a project ends. So we record all of these results in MWater. It's reviewed by the project staff and also by HQ. And this framework really helps us to identify risks before they affect the water quality, as well as address them early once they have happened. So for the purposes of this study, we really wanted to review, visualize, and summarize water quality monitoring tests using a water quality index. So for the purposes of this study, we included 41 water points. These were all constructed in the second half of 2022. So we looked back at a cohort of water points. You can see in the map where those were located. This ended up being 32 in 32 in Ethiopia and 9 in Uganda, primarily being community water points. And we included all of the water quality monitoring tests associated with those water points from 2022 to July 2025. So that was 143 in total. You can see here the water quality index calculation we used. So we assigned a weight with each of the 4 parameters we included from 1 to 5, 5 having the highest impact on health, and then 1 having the least. All of these were calculated and visualized in Power BI. And you can see our results there on the right side. The vast majority of water quality tests ended up in the excellent category, which is of course what we want to see. These had a grade less than 50. And then there were 2 water points where they had a water quality test that was rated as unsuitable for drinking, which is a score above 300. So these are the 2 tests where we found the scores above 300. These were both in Ethiopia, 2 villages very close together, both on the second regular monitoring timeframe. So this water quality index correctly assigned a high water quality index for these water points. They were found to have readings of E. coli. They were still very low readings of E. coli, 1.5 and 3.4, but of course, according to the WHO, any level is not acceptable. And we found, you'll see this in the next couple of slides, both of these were mitigated by the next time we did regular monitoring. This is really the rest of our results. We excluded those 2 E. coli tests because it made our charts look different. And so we can see some overall trends here. What we have is the type of test as well as the time that it was taken. So the first, second, and third of each test type. So you can see some trends here. The median of the institution sustainability monitoring slightly increased over time. And then the maximum for the random sampling slightly increased over time. But overall, everything was pretty good. All of these results were still under 50, except for those 2 that we found to be greater. In terms of regional differences, we found that in Ethiopia, the median was a little lower. It was 34.8. And then in Uganda, our median was 39.2. This was mostly due to the presence of nitrates in the community. They were still under the safe levels by the WHO, but they still had a slightly higher reading on this water quality index. These are all of the places where the WHO safety framework, the result went beyond it. So a place where a risk was identified. You can see the majority of them were due to issues with pH. And then in green, under regular monitoring 2, you can see those 2 E. coli risks. And then we also had 1 case where turbidity was higher than 5. Interesting thing to think about this is that all of these still, besides the E. coli readings, received WQIs under 50. So they were rated as safe, and yet they were noticed as risks according to the WHO. So just some overall reflections on this analysis process. Like Adrienne said, this regular monitoring system can help us to prevent contamination as well as detect it and trigger action. Automated tracking systems, such as using dashboards and Power BI like we do, can help us to enhance visibility, reduce the staff burden of analyzing all of that data, and also promote our performance of making sure we monitor all the places where we plan to. And then water quality indexes reveal overall water quality trends, but we need more data to really understand if they accurately reflect health risk. And then along with this, we also should continue to evaluate water quality tests on a pass-fail basis so that we know when we need to take action. And then next steps, we would also like to include in this more information about the responses of our service providers. Obviously, when there's an issue, we want to make sure that our service providers are following up appropriately and on time, so we'd like to collect more data around this and include this in our analysis. We'd like to further develop this dashboard to continually assess trends in water quality index and expand it beyond just this small analysis. And we wanted to continually assess the issue of health risks and WQI, how those things work together, and whether it's an accurate assessment of health risks. All right, so I think we're ready to open it up to any questions.
Thanks, Adrienne and Sarah. How are you thinking about assessing health risks across your programs?
I think for now, so we do collect a lot of health data just in general. The purposes of this was just to look a little deeper at our water quality data specifically. So within water quality indexing, all of that, I think it'll just include expanding this analysis to our wider data set. You know, we have data all the way back to 2016. So looking at that, just looking at, you know, the levels of issues like E. coli in the water, and just really reflecting on, you know, does this high or low value in the index really reflect what's going on in the community?
Thank you so much. This was wonderful. I really appreciate the idea of indexing water quality to get sort of a general idea. It was wonderful the amount of data that you guys had. I was curious if you find that potentially more regular data collection would be beneficial, or if that would change your perception of the water quality, given that those are frequently tested, you know, a couple times a year, which I know can be kind of challenging programmatically.
Yeah, so of course we would always love to have more data. This is just kind of what we've come up with to get the most information with the least amount of testing possible. That's why we have the regular monitoring, but then also we collect it annually for institutions and then also randomly. So we get just a lot of data from different time points with that. I'm sure if we had data more regularly, like, you know, on a monthly, quarterly, yearly basis, we would see maybe even more risks. We don't know. But this has just been our best fit solution with the time and resources that we have.
I think perhaps it's notable that we're not, this is including random sampling in addition to time-based. So we do have maybe the opportunity to catch water quality results that are associated with certain risks. This is not, though, a risk-based approach to sampling. So that's a potential area for improvement and further reflection. Just want to point that out. Thanks.
Henk Holtslag of the Smart Center Group. As you probably know, a lot of contamination happens also in the transport and the storage at home. I'm not sure whether this applies here, but do you have information also on the quality of the point of use?
Yes, so we don't have direct water quality data on that, but it is something we include as our wider Vision of a Healthy Village program. So one of our main indicators we collect in our evaluation surveys before and after we do a project is safe water storage. So assessing whether a household's storage containers are covered, narrow, and clean, narrow-mouthed, I mean. And so that's something we really make sure to emphasize in our programs. We can provide safe water, but if it's ultimately getting contaminated on the way home, you know, it's like, what's the point? We want to really just reduce diarrhea and focus on a better quality of life. So we don't have direct water quality data on that. I would love to do a study where we actually go and test, you know, at the point of use, what is the actual water quality by the time it gets home.
And just really briefly, this is not included in this data, but we have some of that from work that we've done in the Central African Republic associated with carbon project that we pursued. So we collected samples at the door of the household from the container that the community members were using. So we do have that data that was not included in this. And those were on systems that included chlorination, which is also different than the examples here.
Thanks very much. And kind of a related follow-up question. I'm sorry I missed the very beginning, so maybe you're explaining it, but I was wondering if the taps or pumps that you sampled were disinfected prior to sample collection, because those can also be, they can harbor E. coli contamination, which can skew the results. And a second question, I wondered if you collected sanitary inspection scores as a metric of water risk when you were doing the water quality testing.
Take those both.
Yes, so I'm less familiar with the actual process of taking the water quality test. I'm less involved in that. Maybe Zara who knows little. But we do have regular standards that we follow to make sure our water quality tests are accurate. So I would assume that includes some kind of disinfection before we take the actual test. And then, second question.
Sanitary inspections.
Sanitary inspections, yes. So every time we collect one of these water quality tests, we actually do a sanitary inspection. We just didn't include it in this analysis. And then, yes, we're also looking to expand that potentially to buy annually at the water points so that we can work on any issues before they come up and before they actually contaminate the water.
Yeah, and I think I just wanted to emphasize again I think part of our program that's evolving is how does the service provider group then take action and help to support response. Most of these samples and the results were very positive, but if that changes over time and as our role and support for service provider groups strengthens, I think that will create more of a dynamic in the way this data is used.
Let's give Adrienne and Sarah another round of applause. All right, up next we have Emmanuel Olela from the Millenium Water Alliance.
Okay, thank you so much, everyone, for this session. I'll be speaking about assessing household water insecurity among pastoralist households benefiting from water interventions within the Kenyan context. My name is Emmanuel Olela. I work for Millenium Water Alliance, and I'll be sharing some of the findings based on the HY's use to get some of the data from for this particular study. So these are just normal statistics. We know 2.1 billion people still don't have safely managed water systems. Basic water access is dropping by 4.6 over time, and then stagnant access in the urban areas. And therefore, for this study, we tried to focus on the household water insecurity scale, just to understand some of the lived experiences. But this was going to focus on the arid and semi-arid context entirely. And so for those who are not familiar with the HY scale, this was a scale that was developed by a team of developers, thanks to Dr. Sarah Young, who was leading that. And this has 12 items to understand some of the basic lived experiences for 12 items of the scale, including worrying about water access, interruption of water access, among other 13 other items, 12 other items. And so the context was in Kenya. We know that in Kenya, 80% of the land mass is arid and semi-arid, and that is what we really try to focus on in terms of the interventions. And this serves about 18 million people in that area, and we know that our areas are really prolonged drought, erratic rainfall up among high temperatures that affect water access. And this is data that we collected from one of our programs, Rapid Plus program, which is focusing on improving water access to pastoralists in that particular context. And so I'll be speaking about the objective and the purpose for this and why we did this. This was to assess the utility of the validated HY scale in this particular context, looking into 3 objectives. So the first 2 objectives are conceptual, looking into extending the evidence among the other validated research work that has gone into this, as well as testing it for fit for the ASAL context. And then the second is just to look at, again, so conceptually, how the HY is representative of the objective measures of water, which is collection time, adequacy, and distance as well. And this was just to examine that and also ensure that there's some representative, because the scales, the 12 items contribute to a latent structure, which is the household water insecurity. And then the last objective was just to look into the experience in terms of using the scale. So this was based on a random sample, which was 1,435 in the 5 counties, and undertook quite significant analysis on this, looking into the exploratory factor analysis to get the issues of reliability and also convergent and non-groups validation analysis just to check that this is representative of the land-earth construct against the objective measures of water. And then lastly, descriptive, which was more or less trying to understand the actual results. And so into the findings is that based on the inter-item correlations, we were able to establish that there's quite some significant, strong internal consistency, and the high reliability of 0.9, which is quite high and above the validated research work that has gone out there, because we know that has been between 0.84 to 0.93. In Argentina recently, they established 0.95, and as well as the initial cohort for a study in Kenya, which was done in 2019, was 0.97. So this is high, showing that some of the items, based on the context, are quite overlapping, as well as it also hints to item redundancy, but based on the context that we are in, we realize that the households are actually living a homogeneous experience where worrying, interruption, among all those other items are experienced on a daily basis. And so these households' water stressors are similar and experienced at the same time by the households in the ASAL. And that's why this contributes to the high correlation that leads to the high internal consistency based on that context. Looking into objective 2, which was to look into the latent construct of household water security in relation to the objective measures of water, which I talked about, collection time, adequacy, which is relating to quantity and distance. So looking into multinomial regression models, we did 2 single predictor and multivariate. And what this means is that for collection time, households that spend 30 minutes, less than 30 minutes collecting water, those really are in the low water security when it comes to HYs, and this has increasing estimate value. So looking at that, then we realize that there is a negative and significant association with that particular objective measure. For adequacy, inadequate source, again, households with inadequate source, that shows that there's a positive and significant association with households that have inadequate source, scoring within the higher scores within the HYs, as well as distance. For those who cover less than 1 kilometer, there's a negative and significant association to that when it comes to HY scores. So this generally for water practitioners mean that collection time and adequacy are key predictors of water insecurity, and that's what we should try focus on addressing whenever we're doing our interventions. The multivariate regression model was just to confirm the analysis that was done, which again, it reflects the predictor model that we found in that. And the known groups analysis, this was just to look at when using the HOS scale, can it differentiate between different groups that we already know that have differences, especially, for example, for households that spent less than 30 minutes, then households that spent more than 30 minutes, do they have a difference? So is that distinguished? Can the tool or the scale really determine that? And yes, we did. The mean HYS total score for households spending less than 30 minutes was 4.3, while the other group was 8.4. So it means that the scale indeed distinguishes that, and this contributes to the fact that the HY scale can be used to assess in the context that we were collecting this particular data. And then the last is just to look into the application, which is the practical bit of using the HY scale. For the area we were implementing these interventions, which is the northern Kenya, 62% scored not to marginal, so that means majority of the households in this were on the low household insecurity. And looking further into the source and distances, then you still realize that majority of these households, based on the interventions that have been done, there's some improvement in terms of generally water access. But we realize that adequacy and collection time are strongly influencing the household, influence the HY scores. And so into the discussion, one was to ensure that we conceptually understand the HY scale in terms of the items, how they contribute positively to the internal consistency. And by just the corrected inter-item R drop, we were able to realize that each item contribute positively to the overall scale. And into the second bit, which is the excellent reliability, 0.9, yes, it's high and it can indicate some redundancy or overlaps, but ideally the scale is demonstrating the actual lived experiences, which means that these households experiencing the water stressors in a more homogeneous way. And then the scale also aligns to the objective measures of water, which validates and confirms that indeed it can be utilized. And the collection time and adequacy, as I had mentioned, are very strong predictors of water insecurity, as well as distinguishing groups. Then lastly, just to key takeaway, is that yes, the tool can be used in the arid and semi-arid lands, which is something that is key. Collection time and adequacy, water practitioners should be very key on ensuring that collection adequacy is something that is key. Asals have homogeneous lived experiences. That is something that we confirm. And then the tool can also be used for water infrastructure targeting, as well as being used for M&E purposes for regular monitoring, as well as ensuring that holistic interventions are held. And the beauty of this is that we use the findings to enhance one of our carbon financing programs for operations and maintenance. And the results will help us to model that better into now having more reliable and sustainable water systems for the programs that we implement. So this just to acknowledge the authors, the advisory team, institutions, funders, and my contacts are there as well. And for now, I'll take questions. Thank you.
Hey, thanks for the presentation. Great work. I had a question about the original data set and some of the maybe inter-overlaps that you're seeing. I'm wondering if you could just talk a little bit more about how homogeneous or how heterogeneous the actual study set was. Like, was it very different community types, very different geographic distributions? If you could talk a little bit more about that, I'm interested in understanding how that plays in with maybe some correlations.
Okay, thank you so much. Yeah, so the data set was collected in 5 geographic regions that is all primarily arid and semi-arid, and so that means that the population there held similar characteristics, and these are pastoralists with a more homogeneous, they share lived experiences in terms of long distance to water sources, high temperatures affecting their sources, as well as frequent breakdowns. And so that's the population that we collected in data. And that could also be contributing to the high internal consistency. So that means that when a household responds to a specific question, then they are more likely to respond in a similar more way, but as well as the redundancy, the possible redundancy could also be looking into that they cannot differentiate the emotion they're using when responding to the specific questions. So worry and fear and shame could be meaning the same thing when they're being asked questions. So all these can contribute to the high internal consistency, and that leads to the systems overlap. So one way to solve that is just to look at item reduction by employing a method like item response theory to really check if we can have a scale that has a shorter items, and then see how that goes. So we'll still be doing further research and analysis on this data. Thanks.
Thank you for your very nice presentation. I was wondering, could you explain a little bit more about the intervention and you measuring household water insecurity both before and after the intervention? Because I understand that was one of your key objectives. And if you could just explain that a little bit more, that would be helpful.
Pardon, can you just repeat that, please?
As I understood it, measuring household water insecurity both before and after your intervention was a key objective here, unless I was wrong. But could you just explain more about, maybe I misinterpreted it, but how you explored HYs in relation to your intervention?
Thanks. Yeah, so the data was, this was a cross-sectional data that we collected at during one of our evaluations. And then we will be collecting a second round of data next year, just to also check in terms of the scores for that. So one of the things that we will be doing, especially now based on the first cross-sectional data that we have, we'll be able to cross-examine the next data set that we'll be collecting next year in the same region. Yeah.
Thank you so much for your presentation. I'm curious how you're thinking about using HYs. Are you using it to replace other modules in your surveys? Is it providing additional information that's useful for programming decisions? How do you have a vision for how it's going to be useful for your programs?
Thanks. So the HY's results are actually helping us with understanding some of the specific lived experiences in terms of the emotional and physical burdens that come with access, and not just into, because the objective measures of water usually have very specific metrics in terms of distance and time, and you'll be looking at number of people you've reached, but actually by understanding much deeper into the emotional and physical burdens of these individuals, then you're able to target better when you're doing water interventions. It can also help you with the issues of targeting individuals, but also citing of the water systems that you'll be doing based on the understanding that specific areas have more needs than the others. Yeah, it could be that you are targeting a region, but there are specific households that are on the extreme end of water insecurity, and so those are the households, or those are the areas that should focus more on the resources. Yeah, thanks. Thank you.
Thanks, Emmanuel. Up next, we've got Timothy Purvis from the Water Institute.
Well, hello and welcome everyone. Thanks for joining this afternoon. I am Timothy Purvis here at the Water Institute at UNC Chapel Hill. Thanks for coming out to the conference. I am presenting on behalf of my co-authors, including Dr. Kronk, Dr. Fisher, who's somewhere here in this building, and Keshav Sri Venkatesh, who recently graduated and actually pushed forward a lot of this work, so I want to give him a shout out. We're presenting on the question of what is in your network, and we're looking at a case study using systematic supply chain mapping of lead and drinking water infrastructure. So to kick us off, I want us to all be on the same page of what a supply chain map is. Essentially, it's a tool by which we take in a lot of information and data to understand some key questions, such as how are products made? What are the raw materials that go into making that product? What are all of the intermediate steps that you need to go from a raw material to a finished good? And who are the end users of those finished products? To do this, we take in trade information, we take in information from organizational websites, from manufacturers and distributors, and also look at online retailers like Amazon or regional equivalents. This generates process maps, and so a process map is looking at a single product. And so by grouping together multiple of these process maps, looking at individual components, we can get a larger supply chain map for an overall product. Now, this is great for identifying possible intervention points, which leads us into how supply chain maps are typically used. They're used in the agricultural and manufacturing industries, typically to say, how can we improve our shipping times and how can we protect
for food safety. So what you're seeing over here is an example of a supply chain map for Reese's peanut butter cups, which I chose because it is Halloween season. So what you see is there's a lot of raw materials coming from all over the globe, including some of the ingredients that go into that, which would produce the chocolate or single product or a single component, and then some of the paper goods and the plastic and things to make the packaging that all gets processed in a single facility. So while supply chain maps are really well understood for logistics, and for food safety, it's never actually been applied to drinking water infrastructure. So we're interested in seeing how it could be used. Now, one other thing I want to cue you in for is the HACCP framework, which is also from the food safety side of things. HACCP is the Hazards Analysis and Critical Control Points tool, and essentially, I'll jump the gun a little bit, it requires a flow diagram of the complete process, essentially taking from a raw material to a finished product, which sounds a lot like a supply chain map, to then identify where there are possible points of intervention to protect from contamination of whatever the finished good is. So we wanted to understand how could a supply chain map of drinking water infrastructure kind of link with this HACCP framework. Now we're applying all of this to understand supply chain maps for lead in drinking water. The reason we chose lead, well, first of all, lead has a lot of very negative adverse health impacts that can have lifelong impacts, including decreased cognitive function for those exposed as children, lasting through their entire lifetime, but also decreased cardiovascular output, higher rates of death, lots of bad global burden of disease problems. This was a problem to such an extent that in the 2020s, WHO put out a guidance on lead in drinking water that summarized to two conclusions. The first is that the primary source of lead in our drinking water is leaching from lead-containing materials in water systems, also known as the supply chain is contaminated with lead-contaminated products. And the other thing that was interesting is that the conclusion was prevention is the most effective action. And so we know that lead is harmful, it's important, it seems to be coming from our supply chain. And so in theory, it is preventable with supply chain intervention, but we wanted to understand what that might look like. So we jumped in with a case study of Ugandan drinking water infrastructure. Now in Uganda, 2/3 of the country is using non-piped drinking water, of which that is primarily hand pumps, and for which the India MARC series is the predominant model far and away. There is also piped infrastructure, with about half of urban Uganda having access to piped drinking water networks. So we're not just interested in a supply chain map for hand pumps, but also for piped sources. And there is a growing use of mechanized boreholes, which operate, as we found, on a completely different supply chain using a different suite of materials and largely different vendors. And so we also wanted to see what alternatives there are to potentially lead-containing materials. Now, the reason why Uganda was selected is partially because of this use of the India MARC system, where older models of the India MARC hand pumps are using known lead-containing materials in some manufacturers, and those are galvanized iron, galvanized steel, and brass. And so if we look over here, all the things that are circled in these colors are potentially made by different manufacturers of these lead-containing materials and are often in contact with drinking water, especially some of the parts that are underground that are in extended stagnated contact with that drinking water. So with all this, we wanted to understand how supply chain mapping can be applied to the Ugandan context to understand and identify possible intervention points to prevent future lead contamination. So I kind of already explained this, but we went through and did a supply chain map following essentially the process that's laid out by the manufacturing sector of identifying the raw materials, the manufacturers, the intermediate products, the finished products that get made, the vendors, whether that is from one continent to another or also in country. Then we looked at the implementers who are purchasing, and then the final communities that end up being or using these components. And so we integrated all of this into some of our supply chain maps. And so the first set that we have is looking at those hand pumps and the mechanized pumps. The first thing that we noticed, and it shouldn't be a surprise, the India mark hand pump is primarily manufactured in India. This wasn't a surprise to us, but what was surprising is that there is a wide range of manufacturers within the country of India that are responsible for manufacturing. They end up actually having a lot of connections in their raw materials. But what ends up happening is that these 20 or so manufacturers across India end up using a lot of galvanized materials, especially for the tanks, and they use potentially lead-containing brass in a lot of the hand pump cylinders themselves. And so all of that indicated that, yes, there's potentially lead coming in. So what ends up happening is that these 20 or so manufacturers end up shipping out of about 4 or 5 different ports within India, and a lot of this ends up entering through the key port of Mombasa. Now, an initial HACCP framework would say that, great, our intervention point should be the port at Mombasa. But this is a little difficult. Reminder, we're looking at what's happening in Uganda. The government of Uganda has no authority over the trade practices within the port of Mombasa. So the next step is that a lot of these materials make it by road to the trade port of Busia, or the trade crossing of Busia between Uganda and Kenya. And so that actually may be the first time that the government of Uganda has some intervention that they can stage. We also found that there was a different supply chain for our, our solar-based, our solar mechanized pumps. And as I mentioned, a lot of these are manufactured using stainless steel. But one thing that we noticed is that there are a lot of manufacturers in South Asia, not just within India, but actually more manufacturers and vendors than what is initially identified on the parent kind of company websites, indicating that some of these may be not authorized, and therefore we can't certify all of the materials that they use. Now, when we're looking at pipes, things get a bit more difficult. The capital, it's not as capitally intensive to manufacture pipes, which means that it's not concentrated among just a couple of firms. There are firms all the way from Indonesia and China up through homegrown industry within Uganda that are manufacturing galvanized pipes that seem to be available in the market for purchase. And so this means that we can't have as easy of one single intervention point. Rather, for pipe infrastructure, it may be that we have to go through the purchaser and work as education for our NGOs, our utilities, and our government partners to make sure that they're aware of the importance of doing material evaluation to prevent future lead contamination. So our takeaways: is lead entering the supply chain? Yes, we found that from a market analysis at least, yes, there is definitely the potential for lead to be making its way into what is installed in the ground for our drinking water infrastructure in Uganda, primarily through our hand pumps that are using galvanized iron and galvanized steel, which are largely imported, but then also through the production of galvanized materials and some smaller brass valves and fittings that are being generated or manufactured and sold nationally within Uganda. We identified some of the import routes, so the Mombasa, Kenya port, the Busia border crossing where Uganda may be able to do some verification, and Entebbe airport for some things coming from outside the East Africa region. We also found that lead-free alternatives do exist. The next step in this process is to do actual on-the-ground research. This was all desk-based thus far. But we are seeing that they are available using stainless steel and at comparable price. There's also that growing use of solar-based mechanized pumps, meaning that there are lead-free alternatives in the market. So some of the possible interventions we identified through the HACCP framework. First of all, our material verification pre-shipment. We want to operate with the idea that it is best to solve contamination as close to the source of that contamination as possible, because that is where it is simplest. But unfortunately for Uganda, this means that we have to work through the actual recognized mechanisms of a different country and build buy-in through manufacturers in South Asia. We could then follow this up with an intervention that is doing spot verification within the region, but this would be an add-on. This wouldn't be the primary intervention. Really, the ideal is that we're cutting lead out of the entire drinking water infrastructure supply chain. The other intervention that we identified was that end user outreach, so focusing on our local governments, the utility purchasers, a lot of the major NGOs, making sure that they're educated as to the potentials of material evaluation, how to conduct them, how to get a third party to conduct it for a manufacturer, and then potentially how to integrate lead into a HACCP framework, which is actually quite similar to the water safety plan that a lot of communities are already using. One other thing that we did identify from our HACCP framework, yes. So we could adapt it quite easily. Our supply chain did work. But the other thing that was important that I do want to highlight here is that it's not a single actor that is going to be responsible for solving the contamination of our supply chains. It's going to be sector-wide collaboration from the utilities, the local and national governments, and the NGOs themselves. So in conclusion, yes, there is growing evidence that lead in drinking water is coming from infrastructure, but since we did identify that there are lead-free alternatives in the market, this exposure is entirely preventable, and for not that much of an extra cost. As some colleagues recently published, they can do it for as low as 2% increase in total programmatic costs, and I can share that paper around if needed. We did find some possible points of intervention. I do want to highlight that this supply chain is not unique to Uganda. We had great data for Uganda. This is happening all over sub-Saharan Africa, Latin America. It's also happening here in North Carolina. So it's not just a single supply chain solution, it's the entire world. So with that, I do encourage you to check out the Global Lead-Free Water Pledge and see how you might join in solving the contamination problem. Thank you.
Great presentation. Thanks, Timothy. So when you look at the map, it's just, there's a lot there. Is there a priority? Like, what should we tackle first? Galvanized components, brass components? Like, if I were an implementer and I wanted to say, like, I just, there's a lot of things, like, and I just want to tackle one thing. Is there a priority, or is it just you got to do it all?
No, that's a great question. I think it depends on the type of organization that you're with. National governments, it seems like there's a lot of traction with dealing with the pump market itself. The pushback that we've heard for trying to regulate against pipes is that pipes aren't just used for drinking water, they can be used for anything. And so that's an intervention that we have to go through NGOs and the purchasers. The manufacturers, I think, is what is going to be driving a lot of this change, is building that buy-in so that they understand how the market is shifting and can adapt and move to provide more lead-free alternatives. And so I think that's probably going to be the first step, is working with manufacturers, not against them. Yeah. I think there was one first in the back. Yeah.
Thanks, insightful presentation. As the previous person said, there is a lot to do, and then especially working on the supply chain side, because the pipes are already lead, and you cannot change that some time. It will take long years to change that. But on the preventable side, you have said that it is preventable, and one of the thing is lead dissolves more in hot water compared to cold water, right? So are you doing something on that side of awareness where community can do minimum things to prevent it?
That is a great question. Yeah, it's great that there are other preventative actions that can be taken with existing systems that have contamination. And so things like only using the cold water line on a potentially lead-containing faucet, but then also flushing the system, making sure that at least a liter of water has gone through a stagnant system, definitely decreases some of the lead. And so I think the other thing for some of those existing systems is whenever they go down and need a repair, that's the point where you want to replace the broken component with something that is lead-free to decrease, progressively some of that contamination. Yeah, thank you.
Yeah, thank you. And my name is Paul from Uganda. Yes, just happy to see the facts and that you've just shared. Uganda could be just a sample country, but across Africa, this is one of the biggest issue to handle in future. Because when you look at almost 65% of the access in the rural communities from boreholes, and these are boreholes that are as old as 30 years,
Yep.
and people are still consuming that water. Yeah, and most of these, not only the pump, but even the pipes. Yeah, it's only until 2016 when partners continuously through advocacy pushed the government to stop the use of GI pipes in boreholes. I'm happy that most partners now are using stainless steel pipes instead of GI pipes. The pump is still something to discuss. I'm looking at this research, the results we are discussing here, how effective it can be shared with the government to cause some kind of a little bit of enforcement and control of these imported materials that continuously contaminate underground water.
Yeah,
Thank you.
that's a great question. Thank you, Paul. And I actually want to say a lot of this work is happening because the government of Uganda, alongside the governments of Ghana and South Africa, were actually they were the first 3 countries to sign on to the Global Lead-Free Water Pledge. And so this is actually coming out of work that's being requested by the government. And so I do want to kind of commend the government of Uganda, amongst those others, for taking these steps. And so kind of the next step that comes from this, so this is what feeds into a larger stakeholder collaboration effort within Uganda that will be happening over the next year or so. I think we're at time, but I'm happy to answer questions afterwards. You can snag me. Thank you.
Thanks, Timothy. And please come find our speakers after we finish if you have more questions or to connect on their work. And last up, we have Lucy Tantum, also from the Water Institute.
Great. Hi, everyone. I'm Lucy, and today I'll be talking about a survey pilot and validation study on measuring the role of environmental health services in healthcare worker well-being. So when we're talking about environmental health services in healthcare facilities, these are essential to support safe and high-quality care. And these include services for water, sanitation, hygiene, waste management, cleaning, laundry, energy, and building design. And these are also bundled under the term WaSH in health facilities. I'm using this environmental health services term to kind of convey the larger scope beyond just water, sanitation, and hygiene. And these services play important roles in health and well-being in healthcare facilities. So we often talk about their role in reducing healthcare-associated infection, but they also play other roles in the health and well-being of healthcare workers and patients. And especially for healthcare workers, these services may contribute to better occupational safety and reduced injury, as well as increased job satisfaction, reduced stress or fear of infection, and better worker retention ultimately. And for a few of these impacts on things like satisfaction, worker retention, and mental health, many of these have been described in qualitative studies where workers have gone in depth about their experiences, but there have been fewer efforts to actually quantify or measure these outcomes with surveys. That said, there are many tools from other fields that have measured mental and social impacts on well-being arising from the environment. So this includes in the household WaSH field, tools like the Y scale that we heard about earlier, as well as tools to measure things like sanitation and quality of life or empowerment, as well as tools from healthcare facilities, but from a different disciplinary paradigm around things like person-centered care or hospital safety climate. So we hypothesized that we could use a similar approach and maybe even adapt a few of these tools to measure the experiences of healthcare workers as it relates to environmental health in low-resource contexts. So the objectives of the work were to pilot a survey for measuring impacts of environmental health services on healthcare worker well-being in Zambia, assess user comprehension, reliability, and validity of the survey, and then ultimately produce a final tool that is valid and can be used in future evaluations. In terms of the design, so we had 2 data collection tools. The first was doing an assessment of the facility environment. So this included collecting some information about the context of the water, sanitation, and hygiene infrastructure, services, and supplies at each facility. We then also surveyed individual workers to assess a few different dimensions of mental health and well-being. And this research took place in Zambia, in Southern Africa, and specifically in 2 provinces. So in Lusaka, which is the capital of Zambia, so a large urban setting, and we looked at urban health centers and hospitals, first-level hospitals there, as well as Northern Province, which is a rural area in the north of the country, and we looked at rural health centers and health posts, and 1 hospital. So overall, we conducted our assessment of the environmental health services at 37 healthcare facilities across these 2 provinces. And I'll just go through a few really quick results. So overall, we found that around 70% of the facilities we surveyed had piped water inside of the building. However, many of them experienced water outages, often due to issues with the power or electricity supply, and didn't have water 24/7. We found that 3/4 had flush toilets, with the remainder relying on latrines. Just over half of the wards that we looked at had hand hygiene available, so either having water and soap or alcohol-based hand rub. And then 56% had the recommended 3-bin system for waste management. So overall, we saw that many facilities had gaps in 1 or more essential services that may impact the experiences of healthcare workers. So in terms of the survey, this was essentially a scale development and validation exercise, which we luckily heard a little bit about earlier, but just to reiterate, so the goal here was to create a data collection tool, implement it, and then actually assess whether it is measuring underlying constructs around healthcare worker well-being reliably and effectively. So I'll go through these steps and talk about what we found a little bit for each. So in terms of designing the survey, we were interested to understand what kinds of impacts we could measure among healthcare workers and what pre-existing tools or scales we could adapt to the context. So we identified a few scales from the literature or created our own if none already existed to measure different dimensions of worker well-being. This included job satisfaction, burnout, confidence in infection control systems, hospital safety climate, sanitation, quality of life, and workplace injury and absenteeism. We then pre-tested the survey, and the goal here was to assess whether the survey was easy to understand, acceptable, and relevant to its population of healthcare workers in Zambia. So for this, we administered the survey in a small sample of 20 workers, and we administered each question along with some in-depth probing questions using a method called cognitive interviewing. And the goal here is to understand how the participants are actually interpreting and thinking about the questions. So basically to see if there are any issues with comprehension or if their thought process was maybe not what you were hoping to go for with that survey question. Based on this, we made a few revisions to improve comprehension by removing or rewording questions as needed. We then validated the survey, and the goal here is to understand whether the relationships of items in each scale follow the patterns you expect and can measure underlying constructs reliably and consistently. So for this, we administered the survey to 330 healthcare workers across 34 healthcare facilities. And this included any staff at the facility was eligible, including clinical and non-clinical staff. So we had clinical staff from roles like doctors, nurses, clinical officers, as well as non-clinical staff, so people like cleaners or lab techs who also were employed at facilities. And then I'll go through very quickly a few of the kind of high-level findings around the validation. So we looked at inter-item and item total correlation, so trying to understand whether the relationships between items in each scale made sense and they grouped together as expected. So trying to understand whether the score, or I guess response on one item in a scale related to the overall score. And for this, we found that most items showed good correlation, with a few that we could consider for removal if they were not correlating well with other items in the same scale. We also performed exploratory and confirmatory factor analysis, so trying to assess how items within each scale group together to measure an underlying construct related to worker well-being. In an exploratory factor analysis, we found that scales had between 1 and 4 factors for each of the different scales we looked at. And then in confirmatory factor analysis, where we essentially preset the factor groupings, we found that items had good fit with the hypothesized groups. We also looked at multiple groups confirmatory factor analysis to look at how responses varied across the different districts that we collected data in, and we found overall a relatively low level of measurement and variance across those districts. We also looked at internal consistency reliability, so trying to assess whether items that are meant to be measuring the same thing are actually showing similar results. And we used Chromebox Alpha as our measure of reliability. And just to kind of show briefly the results for each scale, so we found that most of the scales had Chromebox Alpha that were close to a satisfactory threshold, with a few that were below that we could consider dropping some items in case maybe those items are showing lower reliability. We looked finally at validity, so trying to see whether items are actually measuring the underlying constructs around health, environmental health and worker well-being. We looked at convergent validity as well as known groups validity and overall found moderate to good results there. So I'll just show really quickly a few examples of that. So for instance, this is a scale of hospital safety climate, so workers' perceptions of the safety of their environment and risk of infection. And we found that workers had higher scores, so they felt better about the safety climate if they had a limited or basic hand hygiene service at their facility, compared to those that didn't have such services. Similarly, this is a sanitation quality of life score, so this was adopted from the Household SanQual Index, and we found that at facilities that had more attributes of safe sanitation present, such as having gender-separated toilets, separate toilets for staff, or hand hygienic toilets, workers gave a higher score than those that didn't have these attributes. So this gives you an idea that these scales are able to detect these variations. In terms of next steps, so we're going to delve further into the association of environmental health services with worker well-being through a cross-sectional evaluation of these data to understand more about how variations in service levels may contribute to different outcomes for workers, and then produce a final survey tool that remains the items that are valid and informative and that could be used in future assessments. In terms of applications of this work, so these tools are valuable to understand the broader set of impacts that might arise from improving environmental health services. So not just focusing on health, but also all of the other ways that these interventions can actually transform individual experiences and communities. Also, this could help for identifying factors that might affect worker retention, which is often an important concern and an economic concern in many countries as well. And then finally, we worked with World Vision for this project, and they were installing interventions in healthcare facilities. They had already been done, but in the future, this could be used to assess changes before and after an intervention and see how that might actually impact healthcare workers. So I want to acknowledge everyone at the Water Institute as well as World Vision in the US and Zambia that played a part in this work, and I'm happy to take any questions. Thank you.
Thank you so much, Lucy. This is really exciting to see all the work that you've been doing. And it's great to see the process of the tool being developed. Can you speak a little bit about the findings that you all came about in those two provinces in Zambia, I believe, in terms of what were the specific, you said burnout, there are a number of different indicators you were looking at. Was there one that stood out to you all, or even sub-elements? I mean, within sanitation, I would think that staff having their own toilet would be a big factor. So rather than just the number, but actually specific qualitative elements of that. Thanks.
Sorry, are you asking which elements of the systems were contributing to these outcomes? Yeah, thanks. That's something I honestly haven't totally delved into yet. I think that's going to be kind of the next step. I would say just anecdotally from talking with healthcare workers and during pre-testing, I do think sanitation was very important because that is very visible and that's impacting people's day-to-day, similar with having hand hygiene on hand. I think other services around things like waste or water might not be quite as visible and maybe wouldn't see quite the same impact, but again, I haven't totally looked at the data.
Hi, I am Preeti and I'm from WaterAid Nepal. So my question to you is, during your survey, did you find any gender-related trends, like in terms of most of the health workers, the frontline health workers being women, any sanitation or menstrual health-related challenges?
Yeah, again, I haven't totally looked at the breakdown yet. I would say that most facilities did not have menstrual hygiene management facilities in their toilets. So a lot did have gender-separated facilities, but they didn't have waste bins or hand hygiene there. So I would expect that that would affect female workers especially. Great, thank you.
All right. Thanks, everyone, and enjoy the posters and happy hour out in the lobby.